this way, right? Now in a type word, now we know forward rotation just means, okay, my jaw goes this way, right? So type 1, the hinge is at your joint itself, okay, so at the TMJ. So the center of rotation will be at your TMJ, so the X. Okay, and a good example would be usually if you open your mouth wide, so your center of rotation is here, right? So the whole thing pivots around this area here, okay? Now it can be caused by occlusal imbalance due to loss of teeth or powerful muscular pressure. Anterior face height usually is underdeveloped, so you will have reduced lower anterior face height. Lower dental arch is pressed into your upper arch. You will have a deep bite. Okay, so how we can explain it is this. Edentulous patient would be my best example. Okay, edentulous patient, no stop, right? So your hinge rotates and overclose. So you know those patients where edentulous patient, the lower lip can touch all the way to the nose? Yes, exactly that, okay? So you can imagine now in a patient who has teeth and who has a forward growth rotation, what happens is you will have reduced anterior face height, right? Because your lower lip can overclose. So anterior face height is reduced. Posterior face height, because it is just a hinge, usually posterior face height is roughly about the same as your anterior face height. Okay? So that is type 1 rotation. Other than that, because there is overclosure of your anterior face height, what else do you get? You get a deep bite. Okay? So patients will have very, very, very deep bites as well. Now the second type of rotation is where your incisor edges, the center is basically at your incisors. Okay, so the stop is here, right? You will have normal development of the anterior face height and marked development of the posterior face height. Okay, so your type 2 is here. And then if we draw a line, now your mandible pivots at this region only. Okay, so if it pivots this way, it goes this way, right? So your chin comes forward, but this grows like that. Okay? So you have a normal anterior face height because this one stops it from going into a deep bite. But because there is growth, what happens is you do get a chin and usually longer or rather bigger posterior face height. Okay? How it translates to a patient is that usually we'll see patients in very nice, well-developed anterior face. From the front looks very nice. You take an OPG or a LETSAF, you see that this jaw, the mandible, very, very square. Okay, like a SpongeBob like that lah. Okay, square type of faces. Usually you get more forward type growth with type 2 classification. Okay. Okay, so marked development of posterior face height, your vertical condylar growth leads to the mandible being lowered more, then carried forward. So that's why you have a forward, we considered it at a forward rotation. The muscles and the ligament then cause forward rotation to occur. Posterior part of the mandible rotates away from the jaw, pivoting at L1, so lower incisor 1. So just remember that the pivot is here. So you can imagine that as your jaw grows, right, because it always grows down this way, but because the stop is here, what happens is that it has to rotate at this level here. So you can imagine if this rotates here, back part grows down, chin comes more forward. Okay? Now type 3 would be at the premolars. Okay? So the center of rotation is usually at the premolars, sometimes due to occlusion, alright? Posterior face height is increased and anterior face height is underdeveloped. So you get a reduced anterior face height here, you get very deep overbite, you also to a certain extent get large overjet. Okay? So you can imagine that the pivot is here, and when we draw a circle this way, can you see how the jaw grows now? So it comes down here, right? So posterior face height increase, it goes up here. So anterior face height here goes up this way. So you get the chin coming forward. At the same time, you also get a deep bite, okay? It's different from if you have the type 1. Type 1, generally the pivot is here, okay? So posterior face height normally is normal lah. Okay, now other than forward rotation, we do have backward type rotation as well. It's not as frequent as your forward rotation. Okay. So in backward rotation, we only have two types, type 1 and type 2. Type 1 is, again, same at the TMJ, where it's a hinge. So this one, again, you just imagine your mouth opening. When your mouth opens, the hinge is at your TMJ. So that when you open your mouth is a type 1 backward rotation. Alright? And the type 2 will be at the premolar region. So let's look at type 1. Caused by raised bite. So if you have patients where you were treating them and then suddenly you have an AOB, you have caused them to have a type 1 backward rotation. Now in terms of development also, what we can see is that you tend to have a increased anterior face height, normal posterior face height, okay? Can you imagine? Just imagine like your mouth opening this way lah, right? So when your mouth opens this way and you are growing, your bones and all, they will try to meet each other, right? Our body always tries to adapt to the norm. So in this kind of patients, you will see them very long anterior face, maybe possible increased vertical maxillary growth, so very gummy smile. When they smile, immediately you see 10 millimeters of gums. When they try to close the mouth also, it's always strained because anterior face height is so long. Okay? Type 2 will be at the most distal occluding molars, right? So occurs in connection with growth in the sagittal direction of the mandibular condyles, retrocline lower incise. You will tend to get retrocline lower incises. Alveolar prognatism is reduced. You get decreased interpremolar and intermolar angles. Okay, so premolars and molars are inclined forward in relation to the maxilla. So basically what it means is that the pivot is around here as well. Again, it's not going to be as bad as type 1. Type 1 is basically just really a hinge that really opens. Usually what we see in terms of growth can be more of a type 2 because this one, then the pivot will be at your molar area. Okay, so here you can see posterior face height again normal, but the jaw growth starts to swing down at the pivot area. Okay, so sometimes your lower incisors, because they are swinging down this way and our lips try to keep them close, right, we can find that our lower incisors are retroclined. Okay? Right. So what is the relevance to growth rotation and why is it so important for us in orthodontics? Okay? Now it helps us with growth potential. Okay? So if we have forward growth rotation type of face, it helps us with anterior posterior, right? So for example, if you have a patient who is maybe 12, boy, still growing, and we can identify that this patient actually is a forward type growth rotation. So you will be able to see cases where you have, wow, 6 mm, 8 mm overjet, non-extraction. You finish the case very nicely, convert the patient from a class 2 to a very mild class 2 or even almost class 1. As opposed to another case where same problem, also 6 to 8 millimeters overjet, but after the case, right, he's nowhere close to a class 1. In fact, overjet also maybe only you improve by 3 millimeters like that. Why? Two different growth rotations. If I have a patient which has a forward growth rotation on one and then another patient backward growth rotation, the outcome will be very different. Okay? So patients with forward growth rotation, better AP growth potential, right? So it will help us for class 2 type of cases. Okay, it is usually associated with very deep bite, low Frankfurt mandibular angle, and they tend to have prominent chin, or they will develop and have prominent chin. Okay, they can have a reduced lower anterior face height as well. So like I said, better potential for class 2 growth modification, favorable growth to redirect class 3 skeletal pattern. Now again, this one depends when we talk into our class 2, class 3s, but this is more into interception already, alright? Now for us, what is more relevant is that we want to correct this deep bite stability. So any patient, square jaw, deep bite, you want to treat this type of patient. Number one, very difficult. Number two, stability will be an issue as well because of the way the jaw will keep growing. Eventually, you will learn that actually we all keep growing to a certain extent. Even when we're older, we do keep growing. So of course, growth will tend to follow our growth rotation depending on what we are genetically programmed to do. So in a patient with forward growth, if we don't finish them in a good overbite, 10 years down the line, patient will then chew themselves back into a 100% or 90% overbite again. Okay, so that we call as relapse also. Okay, other things we need to know in forward type growth rotation patients, tooth movement usually slower. Okay, so slow space closure, right? Their bite strength usually a lot stronger. So generally, most forward growth rotators we can see that they got very nice developed faces, low angle, strong jaw, reduced low. Some patients reduce low anterior face height depending on what classification, right? Type 1, type 2, type 3. Okay. So because of that, stronger PDL, slower remodeling, or rather just slower tooth movement in general. Okay. They tend to develop deep bite for younger patients, so you need anterior bite plates, and also because the way of the teeth is rotating, right? So when your jaw rotates forward, you have your lip here and the teeth, right? So if I have a forward growth rotation, okay, now it doesn't really matter whether you can figure out is it type 1, type 2, type 3, okay? All you have to know is patient is growing forward. Okay, now in a forward growth rotator, what you will expect is, yes, you will have slightly reduced anterior face height, number one, unless it is a type 2. But what you will see is you tend to have nice chin. Okay, why some patients have very nice chin and why some patients absolutely no chin, right? So in a patient who is class 2 but have very nice big cortical bone, have you seen SF like this? Where the chin just sticks out so much like this, okay? This is due to forward growth rotation. Okay, so that tells you that you can really, you want to procline the teeth, you can, but you will deepen the labial mental fold. For some patients, it's not nice at all. Okay? But another thing that you can expect as well is, as this grows forward, your lips start to press on the lower incisors. Can you see the lip relationship to the lower incisor? So can you imagine if this is growing forward, right? Your lip is a soft tissue, it will always want to close. So as it closes, it will press on your lower incisors. What happens is, you will get this. Okay? So that's why some patients, the parents will tell you, oh, when he's young, he looks okay, everything come out nice and straight. But as the patient grows older, teenager, start to see crowding. Why? Because of the growth pattern. Okay? So in these kind of cases, again, if you push them back out, but the patient has a very strong mentally strain because of habit, the moment he stops wearing retainer, everything gets pushed back again. Okay? What about backward rotation? Now, backward rotation in relevance to orthodontics, number one, we have poor AP growth. Okay? So patients with backward rotation is the opposite. It will eventually grow this way. Okay? So your jaw swings down this way. Can you see that? No chin at all. Right? no nice chin. Forward growth rotation, it will grow this way. Backward growth rotation, it will grow downwards this way. Okay? So it's associated with long anterior face height. Basically, your chin is down here. So if you measure, this is forward growth rotation, this is backward growth rotation, right? So some patients, you see the chin super long. If you have patients like that, long face, very long chin, okay? So tomorrow we'll be able to learn how to pick them out, okay? So what does it mean for backward growth rotation? Maxillary teeth lose anchorage faster, okay? Usually backward growth rotators, their bite strength not very good. So because of that, PDL ligaments not that strong. When you are starting to move teeth, right, these kind of cases, they drift very fast. So space closure can be very fast. It can be a good thing, it can be a bad thing, okay? And less responsive to class 2 growth modification. Why? Because growth is not ideal for you. Say for example, this patient is a 10-year-old and you tell me, doctor, can I give a twin block? Sure, you can, but look at the way the patient is growing. It is growing away rather than this way. So in a 10-year-old, you give a twin block because of this growth. Remember, condyles, they are not growth centers, right? They're just growth sites. So you stretch them more, you get a bit more growth potential forward. So that's why some twin blocks, they work very well. Some twin blocks, they don't work at all. Why? Because their growth direction is not in your favor. So these kind of patients, no choice. Either you accept, otherwise, in the future, they will do surgery already, okay? So less ideal for class 3 growth modification as well due to potentially more vertical growth. Now again, class 3 patients, you will have some patients where it's good and bad actually for me. If you ask me, backward growth rotation, some patients, they are class 3 but very mild class 3. This way. Okay, and you have downward backward growth. What happens is that if you have a patient like this, sometimes they do develop into a class 3. Now, when we talk about growth modification for class 3, those days they try to press. Have you heard of chin cup before, right? So it's like this gear thing that they wear and they try and press this downwards. So patient with forward growth rotation, they redirect the growth and cause it to go down this way. To a certain extent, it does, but eventually the moment you stop, then it will kind of start coming forward again, okay? Whereas for a patient who is already downward and backward growth, it doesn't mean that it will just swing down this way. You have always remember there is an AP potential, so forward growth and also this way, okay? A backward growth rotation basically is this way, but AP wise, mandible also will grow a lot, okay? So more difficult to settle, and usually you tend to get AOB. So you get patients with class 3 AOB type cases if it is a class 3 patient. Okay? Okay, so now we go into growth prediction. Now, how do we know, like doctor, like how do I know whether this patient is forward growth rotation or backward growth rotation, right? You look at the face, then like, can you tell that I'm a forward or backward growth rotator? To a certain extent, a little bit. But then those patients who are, maybe the faces are a little bit more out of the ordinary, then it's okay, it's very clear that you can tell. But how can we tell? We usually are able to use our x-rays. So LetSef will be able to help us pick out certain key points. Now, in terms of Bjork, he did a very interesting study those days. Obviously, it's not allowed these days. But those days, how he actually came up with this 7 sign is he picked children, growing children, and what he did was he put in metal, I don't know, is it metal rods or metal implants into the skull. And every year or at a particular time period, he will take x-rays. Yeah, those days they can do those. Nowadays, it will never be approved at all, okay? So what he found was that there are actually 7 signs. As he monitored the child's growth, they keep taking x-ray, he sees certain things keep changing and the growth pattern correlates with it. So that's how he actually got his 7 signs, okay? So we'll look at them. Number one will be the inclination of the condylar head. So this one. Okay, so inclination of the condylar head is 1. If it goes backwards, then he says that it is a backward rotator. So condylar head is inclined backwards this way. If it's forward, this way, then he said they tend to have more forward rotation. Okay, next one will be curvature of the mandibular canal. So again, if it's more acute, then it is more forward rotation. If it is more obtuse or sloping, then usually backward rotation. Okay? Shape of the lower border of the mandible is another one. So this part here. Okay? Now patients who have no antegonial notching, then it's usually more forward rotation. So very nice and smooth type of angle. Okay? But in a backward rotator, you will tend to find an antegonial notch. Basically, an antegonial notch is, have you seen? Let's say there is like a notch there. Yeah? So this is what we call an antegonial notch. Okay? And it's very easy to just imagine why we have this. You can imagine that, like I said, downward rotation, there is a stop at the posterior molar area, right? So at this area is where your jaw starts to rotate downward and backward. So you can imagine this part is normal, and then now this jaw starts to drop down this way as it develops. So that's why you get a notch here. So it's supposed to like grow this way, but the body says nope, you're gonna have to redirect. So we redirect the growth down this way. Okay, so you get an antegonial notching there. Next one will be inclination of the symphysis. Okay, so your symphysis here, you will normally see it's nice, rounded, thick border. Okay, so prominent chin, anterior rounding, very nice thick cortical layer. You take a left side, you can see, wow, very nice thick bone here. Usually patients, they will tend to want to shave this off, or if you want to do genioplasty, we can do a lot with this. I can also move the teeth a lot with this, okay? But high and backward growth rotators, because the growth is down this way, but your teeth goes up this way, right? Because we always want to try and meet together. So what happens is you will get very, very thin, okay? Downward type of chin. Okay, so retrusive chin, anterior rounding, absent or thin cortical layer. Some patients you will see this and then just a thin bone this way. Like absolutely no bone here at all. Okay, and why? It's because of decompensation. Okay, alveolar decompensation. Right? Other than that, interincisor angle is another one. So interincisor angle basically just means upper incisor to lower incisor, the angle. Okay, so if it is obtuse, usually forward rotation, deep bite. So deep bite patients, always you have very high interincisor angle. And if it's acute, then usually it is more open bite lah. So backward type growth rotation, okay? Then intermolar and interpremolar angles, usually a little bit hard to see on that side, but if it's an obtuse angle, then it is more forward rotation. Acute angle, more backward rotation. And of course, last one, we look at your lower face height. Okay, so lower anterior face height, reduced face height, deep bite, forward growth rotation lah. Okay, open bite tendency, backward growth rotation. So there are a few things that we can actually see. You don't have to see all 7 signs. Usually if you can pick up 3 to 4, then that will already tell you whether the patient is a forward growth or a backward growth, right? So what can we pick out? Usually, lower anterior face height is the easiest to pick out, right? Immediately you can see on the spot when the patient walks in. Long face, open bite type of case, immediately you know, okay, downward growth rotation, right? Then the rest you see from your left left. So your interincisor you can see from your left left. Curvature of the mandibular canal, usually we'll be able to pick it up from the left left as well. Okay, and inclination of the condylar head also from your left left, right? So these few things will actually tell you. Okay, so these few things will tell you like, oh, okay, this patient may be forward growth or backward growth. Okay, so if a patient, especially if you're treating teens, that would actually help you with the treatment plan a lot already. Right, now I'm going to give you two examples. This is a patient, right? So can you see what kind of growth rotation she is? Roughly forward, right? You don't even have to look at anything else, just look at the chin. How much chin she has, so much chin here, right? So she is class 3, but she is also a forward growth rotator, okay? So for her, she walks with perpetually her mouth open all the time, okay? Why? Is because she knows that if she swing her jaw forward, her jaw backwards, then her chin goes down, so she will look better. Okay, so that is what she does. For class 3 patients, some of them, especially with a CRMI slide, they tend to they always put themselves in a more ideal position. Same for class 2 type patients as well. So class 2, small jaw, what they do is they tend to bite forward all the time, okay? And sometimes when we are not sharp enough or we miss it out, we call this thing a Sunday bite, okay? Why is it Sunday bite? No. In those days, the Angmos, they always go to church, right? Then for them, when they go to church, they have to wear their Sunday best, which means they have to look their best. Yes. So for us, or rather for patients with class 2, they need to look their best. How they do it? They protrude forward so that they will look nice and normal. And you really have to make sure you elicit so that the patient can actually bite properly. So sometimes patient, right, you tell them, okay, open, close, then they just bite like normal, but actually they're biting on the front. And then when you really truly ask them to bite properly, suddenly from 2 mm overjet becomes 5 mm overjet. And if you never pick that out right, halfway treatment, then you're just wondering why my overjet keep increasing all the time. It's because from the start, we put them in the wrong occlusion already. Okay, so usually patients, psychologically, they will try to always look normal. Alright, so this patient was it. So even let's say I didn't check how she was taking the let's have, so she took it like this lah, okay, but actually she is a class 3 patient. So can you see nice rounded cortical bone here? Smooth mandibular canal, smooth lower border of the mandible, no antigonal notching as well. And then look at the condyle, it goes forward a little bit. Yeah? Okay? Then if she is in occlusion, actually her interincisor angle is quite obtuse too. Okay? This patient, again, is a different kind of forward growth rotator, but class 2. So you can see again, slightly reduced lower anterior face height, but very prominent chin. Look at the notching here. Look at the labial mental fold here. So again, even though we have this kind of chin and we say, okay, got a lot of bone, we want to push this lower incisor out, but you will, aesthetically, it's not pleasing for the patient. Okay? So can you see that the lower incisor is squashed into the upper incisor, right? Again, same thing, no notching at all, thick forward cortical, mandibular symphysis is going front, and then the condyle is facing forward a little bit. Yeah, okay. This one, backward. Can see, right? Very obvious. Now you can suddenly start to see, right? So this one, look at that. No chin compared to this patient. If she had a little bit of his chin, she would look so much nicer. Okay, so this one, no chin at all. Very, very smooth. Lower anterior face height, ever so slightly increased. If by right, we have to measure from here. Okay, so here to here, here to the middle of the eyebrow. Okay, ever so slightly increased. And this is her let's have. Of course, she's bimax bimax protrusive. So protrusive lips, but look at the incisor angle, slightly more acute. Okay, chin is towards the back a little bit of antigonal notching here. Okay, come down slightly towards the back.